This is a no-brainer. We all know which one is stronger. And this is just a slide for kindergarten kids, but I just wanted to put it as a reminder that osteoporosis is a continuous process. It starts pretty early in life. And in the next 20 minutes, I'll try to give you a big orthopedic picture. Somehow I'm going to be self-critical also. Uh, I'll be criticizing myself about why that why we don't do justice to osteoporosis. These are the three main ways we get to see these patients. The commonest one is and as of now, when I'm discussing this, I just got a call from my registrar that fracture of the proximal humerus and osteoporotic fracture. The other thing is these aches and pains where elderly postmenopausal people come, investigate, we find they're osteoporotic. And then there are patients who directly come with a DEXA report because they probably attended one of those medical camps and which has shown that this red dot there, and they come rushing to an orthopedic surgeon there. So there's a last lot of these patients who have already diagnosed themselves and they are pretty sure that they will have a fracture soon and they come rushing to you. So just a revision of what are the main causes. I'm not going to elaborate as Dr. Vaishali did. Orthopedic surgeons, we all know it is postmenopausal as the #1 cause. And menopause is not a one-day event. It's probably an event which lasts probably 4-5 years. And it depends on the age and something to do with genetics also. This is a big epidemic which is happening in our world. Soft drinks, especially fructose drinks, excessive alcohol. I think if I need to remind people that the first shop which opened was an alcohol shop. A recent increase has been in this vaping, and I was going through research about vaping, and it does influence the spine in various forms. It increases the incidence of spinal degeneration, disc degeneration, also increases the incidence of osteoporosis, and the substance in it is nicotine there. And of course, the various endocrinal disorders, which I will not tread into this territory there. Now, people ask me, why, sir, why did I get osteoporosis? Why did I get this fracture? And my answer is very simple. You did not exercise when you needed. And this is the #1 cause of osteoporosis. Of course, there are other causes there, but just being lazy leads to lazy bones there. And as Dr. Deshmukh was saying, the peak bone mass is very important. See, at 20 to 25, you will achieve whatever you want to do. This is the highest. This is like your bank balance. You can't earn more than this. After that, there's a downhill course. So higher your bank balance, higher the peak, the lesser the chances that will go down. So you need to build up your peak bone mass. And how do we do that? I think it's not by taking calcium tablets and vitamin D tablets. The #1 is exercise, 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 exercise. And one of the reasons I find Indian women more of osteoporosis because many of them probably had a very sedentary childhood. And this is a picture of the, many people don't know, we have an Indian rugby team. They won the gold beating Singapore in the Asia Pacific Championship. Yeah. Of course, diet is very important. So is sunlight. And these lockdown days, the kids are not getting any sunlight. And diet, of course, because of the junk food which we're taking, we are being devoid of fruits, vegetables, especially protein like salmon, fish, which is a very high source of bone-forming minerals there. The only symptom as orthopedic surgeons which we normally encounter is fractures. And once a patient has a low intensity fracture, we categorize it as osteoporosis there. Then people ask, what is the cause of fracture in osteoporosis. Why does an osteoporotic bone fracture? And the answer is pretty simple. It's a brittle bone. But if you look at the exact cause, most of them are due to domestic falls. Uh, and this is where your surroundings and your house comes into the picture. Imagine this is second only to auto accidents. This lockdown, believe me or not, we all know the number of road traffic accidents came down drastically. There was hardly no road traffic accident, but the domestic falls were there. Every day we would get 2, 3, 4 patients in a hospital with neck femur fractures, humerus fractures, radius fractures coming in, because you cannot avoid those domestic falls there. Maybe you can avoid. So these are the areas where we need to focus. And the reason I'm saying that as orthopedic surgeons, one of our jobs is to actually educate these patients about how to keep their surroundings safe so that they don't fall. No fall means no fracture. As simple as that. There was a study conducted and was published, a very landmark study about, and they found out that the single most factor in preventing fractures in serious osteoporotic patient was to prevent falls. If you could prevent falls, then obviously fractures can be avoided there. And as we know, especially our Indian roads are very prone for fractures, and this is where a society needs to come into the picture. We talk about cancers, we talk about various road traffic accidents, but we don't talk about the poor pedestrian who's tripping and falling down. Have you ever seen people suing the government because somebody fell down in this ditch there? Then, of course, we have these bizarre cases. We all had patients who danced in the weddings and cracked their hips. And of course, these adventurous grandpas who had gone to the picnic with their kids and grandkids and come back with a femur fracture there. The reason I'm putting up this picture here, the household clutter, and this is a serious cause of fractures. My own father tripped on the rug there. He tripped on the rug, just kept just in front of the bathroom, and he had a neck femur fracture. Of course, had to be operated. So you need to make sure that when these patients go back home, as an orthopedic surgeon, I tell them that you need to prevent falls. So I tell the family members that make sure there is no clutter around the house so that they don't fall. And this is the best time you can actually educate them because they are very receptive. Making your house senior friendly. So this sounds a very unsurgeon like talk, but this is very important because 30% of your patients of fractures, fragility fractures, will come back with a second fracture within 1 year. Remember, 30%. So 1 in 3, you will see them again if they survive your surgery. So you make sure you tell them that you need to modify your home, your toilet. Well, this is where the maximum falls happen. So you need to make it senior friendly home there. I regularly tell my patients they need to do some weight training and some balance exercises. And if you can swim, nothing like it. Remember our orthopedics MS days where Wolff's law was a short note or a question which was asked. And we all know that if you load bones, they will form bone. Even at the age of 80, if you can load your bones, they will tend to increase in density there. Just as a matter of trivia, this gentleman here was one of the oldest bodybuilders. He was Mr. Universe, the only Mr. Universe that time. And he's Mr. Monohar Aich. He used to run a gym and he probably expired at the age of 96, I think, 96. And he's from my city, Kolkata. Our very own yoga. I think the yoga day has come, and I practice yoga, and I'm sure many of you do. And we understand that yoga is which gives you flexibility, balance, agility, and also gives you that muscle mass which will protect you from osteoporotic fracture. We need to go back to our roots to understand that why the incidence of osteoporosis and fragility fractures is less. There is no scientific study, but take it from me, we all have practiced in medical colleges and in big corporate hospitals. The people in villages don't have these fragility factors, or to a lesser extent. It is because of their surplus exposure to sunlight, their pretty hardy lifestyle, and their fresh outputs and fresh food there. So sunlight, exercise, and diet. I think these are three simple things which can prevent osteoporosis. I'm not going to touch upon pharmacotherapy because Dr. Deshmukh has given a wonderful chart about the medicines which are available in the market. And uh, uh, she has pointed a very important thing that uh, that this is a complex treatment. So I think we require professional advice. At times, I am at a loss that which one is better. Is it teriparatide? Is it denosumab? Would rather consult my endocrinologist to come to a conclusion there. So this is for my orthopedic surgeons. I'm not going to tell them that what needs to be done in these fractures. They're all highly qualified surgeons. They all do it day in and day out. So these are three fractures: the neck femur fracture, the intertrochanteric fracture. I have a question for people who are watching, and they can actually reply in the comment section at the OrthoTV section there. Uh, the question I'm asking because I don't know the exact answer to it. Why does what is the reason where some people have fractures at the neck femur, the trochanter, the subtrochanteric level? So we have a 70-year-old guy coming in, falling, and can have a neck femur fracture, a trochanter fracture, a subtrochanteric fracture. Because of the pandemic, many patients are not opting for surgery. So I have to revisit my old days where our professors or professors would put this surface traction, pin tractions, and send the patients home. So in fact, yesterday I had to send a patient home because he was not willing to get operated and get admitted. So we put a traction and send him home. And the good old days, probably it would take 3 months for these fractures to unite there. This is hemiarthroplasty of the hip. This is a nail, and this is a dynamic hip screw there. Distal radius fracture, very common, I think, or with the neck femur fracture. And again, a question to people who are watching, orthopedic surgeons. You have an osteoporotic patient, a 60, 70-year-old with a fracture, and you decide to operate. Would you prefer a simple K-wire fixation and a cast or a plate? Because when I put up this question, I get two different answers. And many of us would still probably treat these patients with a good old-fashioned Colles plaster there. The reason I'm putting up this slide, there is a sudden increase in these periprosthetic fractures. Our seniors and professors have nicely performed these hip replacements and knee replacements 15, 20 years ago. And we're now getting to see these periprosthetic fractures. In fact, 3 of my patients landed up with periprosthetic fractures. And these are very difficult to treat, not easy. And with this hip and knee implant there, it's not easy to treat this fracture, and they require a special set of skills there. The key here is not to irritate or strip too much of tissues. So we need to practice MIPO techniques there and put as many screws as possible as spaced out. The length of the plate needs to be longer, and because the chances of failure and osteoporosis are very high there. And you have to mobilize them as soon as possible. You just can't keep them in bed. And sometimes you need to probably change the whole damn implant here like this here. Proximal humerus fracture, pretty common these days. And we all know that most of them can be treated in this simple arm pouch sling there. Some will require fixation. Severe osteoporosis, sometimes it's not been worthwhile attempting to fix these fractures where we have to actually replace them with either a hemiarthroplasty or a reverse shoulder arthroplasty here. Similarly, spinal fractures. This is from my spinal colleagues here, spinal surgical colleagues. Their first line of treatment in osteoporotic fractures is they do a vertebroplasty or a kyphoplasty. Vertebroplasty is cheaper than kyphoplasty because the results are fabulous. Although the 1-year results of conservative and operative treatment are the same, but if you look at the outcomes, the immediate short-term outcomes, they are fabulous. These patients recover very fast. They're up and about, and they're discharged the same day or the next day. So this is my actually my most important slide here is, as orthopedic surgeons, we tend to neglect patients of osteoporosis. And Even I have gone through this phase where I've operated on a patient of neck femur fracture, send him home. The patient comes back after 6 months, one with another fracture, and and I look at the discharge. I've just given one calcium tablet, and the patient has stopped the medicine after a month. That's it. I never bothered to follow this patient up for osteoporosis to actually quantify his level of osteoporosis to find out that what is his level, where do we need to give him denosumab, teriparatide, or bisphosphonates. This is where we need to be aware that these patients need to be followed up in the future. Is and the best time to talk to them there is just after the surgery, when the surgery has been done and they're fine. When you speak to them about the osteoporosis and how you can prevent it, and do you need to give them medications or do you need to refer them to endocrinologist, they are all are very receptive about it, and none of them will actually fall out of follow up. Believe me, they all come back. In fact, they remind me that, sir, you had said that after the fracture has been fixed, you would give me the advice for osteoporosis and what medicines need to be taken there. So the last couple of slides is as orthopedic surgeons, once we have fixed the fracture, we need to educate these patients about fall prevention. Very important, fall prevention, fall prevention. And to educate them to change, it's not possible for them to move into a senior home, but you can actually ask them to change their surroundings a bit, put railings in the toilet, around the bed, make sure that the beds have some side railings where they should not fall down, and put thick carpets around, no loose wires, no loose tools, so that they don't trip and fall. Exercise, even in bed, is possible. Even in bed, exercise is possible, so that the remaining bone mass remains there. Diet and DEXA. Now, this getting a DEXA scan, which after the fracture, is kind of controversial, because a patient who has a fragility fracture, for all practical purposes, has been diagnosed osteoporotic. Because I've seen that even getting a DEXA scan, the patient has got a classic intertrochanteric fracture. The DEXA scan comes as -2, and then you tell the patient that, I'm not going to treat you, but this patient has a high chance of coming back with a second fracture again. So for this particular thing, you probably need to consult an endocrinologist, because they are better equipped uh, and knowledgeable about this particular problem there. So to my orthopedic colleagues is that just be aware of osteoporosis. In the future, probably one of us will land up with an osteoporotic fracture there. So thank you, everybody, and please stay safe.